Christine Laranga is she's a breast surgeon, surgical oncologist at Moffitt Cancer Center in Tampa. And so we were asked to put together a talk about the role of axillary node dissection because it's become an enormous topic and very confusing for surgeons. There's a lot of discussion that goes on in tumor board every week, and so some of the surgeons don't really have a good handle. I'm not sure any of us have a good handle on what to do, but we'll put forth some attempt at doing that. I have no disclosures. So the management of the axilla in node-positive patients is a big topic. So we're going to discuss data that is rapidly changing the landscape of axillary node dissection, and then we'll follow with a discussion about controversial areas that plague us all the time. And we're going to break this down into two sections. The first section is clinically node-negative patients that end up being positive on sentinel node biopsy, and then the second area, clinically node-positive patients found at the time of diagnosis before definitive treatment and how to manage them. So these are the kind of the two major topics and the subtopics that we'll cover. So the other thing that we did, we had an audience response set up, but these were a couple of the questions that we threw out at the beginning, and it was interesting to see what people's responses were. So this was the first question. In a clinically node-negative patient with invasive breast cancer, which of these do you do? Completion axillary dissection on everyone, sentinel node on everyone, or selective use of sentinel node biopsy? Do you limit sentinel node biopsy to smaller tumors and do axillary dissection on larger tumors? So what is your practice? I would say the audience there and the practice here, essentially sentinel lymph node on everyone was the majority answer. And then the other question that came up for the audience was about intraoperative assessment of the sentinel node. Is it not done at your facility, or if so, how is it done? Is it either frozen section or touch prep? And most places frozen section was available, although some smaller hospitals don't have that available. And then it was a pretty even split between frozen section and touch prep as far as how the node was going to be processed. So how did we get to the point where we are in management of the axilla? So we're going to look back at some of the landmark trials. NSABP B32 is a trial that enrolled over 5,600 women that were clinically node negative and had small breast cancers, T1 and T2. They were randomized to sentinel node biopsy alone versus sentinel node and axillary dissection. So most of the patients were identified as node negative, and this study got reported. It was open from 1999 to 2004. It got reported first in 2010, and then has had a 10-year follow-up update. So this is a large trial with long follow-up. And for node-negative patients, there was no difference in overall survival, disease-free survival, or local regional recurrence in either arm. So what this means is that for patients that are node-negative, sentinel node biopsy and axillary dissection have equivalent outcomes. So for a sentinel node negative patient, there's no reason to do an axillary dissection, and this was just a confirmation that the sentinel node procedure worked and that it was accurate enough, because in the big randomized trial, the outcome ended up being the same. The International Breast Cancer Study Group ran a smaller trial, and this looked at sentinel lymph node biopsy versus axillary node dissection and micrometastatic disease. And actually for micrometastatic disease, there was no difference in overall survival. This was a non-inferiority trial, which showed that sentinel lymph node biopsy alone for micrometastatic disease was non-inferior to completion axillary node dissection. So that was an important trial. There was a smaller study called the AARTM, had only 233 patients. This was also a trial looking at micrometastatic disease, showing no difference in disease-free survival. And then finally, the ACOSOG Z11 trial, which is a trial that most of us work off every day, and this was really a practice-changing trial. This randomized 856 women who had clinical T1 and T2 cancers and clinically node negative, and had at the time of surgery up to 2 nodes positive. It then randomized them to completion axillary dissection versus no completion axillary dissection. These were all breast conservation. There were no mastectomy patients in this, and so all the patients received post-lumpectomy radiation. And this trial actually failed to accrue enough numbers. It has slow accrual. It was a difficult trial to conduct because of the dramatic differences in treatment. But on long-term follow-up now from Z11, no difference in overall survival, disease-free survival. So we have now, we have trials ranging from negative sentinel nodes to micromets to macromets with some limitation that, that show no difference. So let's look at a few questions. And again, these are questions that we ask the audience because there are a variety of practices around the country and how people manage these. So this is a typical patient we might see at tumor board, a patient with a 2.5 centimeter invasive ductal cancer grade 2, positive. Positive means ER/PR positive, HER2 negative, with 1 micrometastasis. So if you have with 1 micrometastasis in 1 sentinel node, so does age play into your management of this patient? Would you do an axillary dissection if the patient is young versus older, 39 versus 55? Or would you do an axillary dissection for either, or would you do an axillary dissection in neither case? So does age make any difference in this discussion? Does size make any difference in the discussion? I mean, size of the primary tumor. Same patient, if she has a large tumor, does that influence your decision-making about axillary dissection? Do you do axillary dissection for all large tumors, or do you not? Does the histology matter? If the patient has lobular cancer, does that change your mind? If the patient has microinvasion associated with DCIS, does that make any difference? Does the size of the metastasis matter? If it's micro versus macro, does that make any difference in how you manage the patient? Does the type of surgery matter? If you're doing breast conserving surgery, this reflects the patient population in the Z11 trial. But none of those patients had mastectomy. So can you apply this to patients who have mastectomy or not? So let's look at a comparison of these 3 trials to try to answer some of these other questions. First, all 3 of these, this is the Z11 trial, the International Breast Cancer Study Group trial, and the NSABP B32. So this was the macromet positive, macro and some micromet positive. This trial was the micromet positive. This was the node negative patients. So all of these, excuse me, all 3 of these trials stratified by age at less than 50 or greater than 50 and had varying populations of young women. But even with the age stratification, there was no difference in any of the outcome measures with regard to overall survival or disease-free survival or local regional recurrence dependent on age. So the age thing still makes some of us nervous as far as long-term outcomes, but in fact, these three big trials did not really show any difference in outcome based on age. The other question is about histology. The Z11 trial is the only big published trial that differentiated histology. 6% of those patients were lobular, 82% were ductal cancer. The other two trials don't define histology subtypes, so we don't really know. We don't have a lot of information about some of the less common subtypes, especially lobular cancer. In terms of size, these trials mostly looked at smaller tumors. The maximum was T2 for the Z11 trial. There are a few larger tumors in the other two trials, but those are small numbers. There was no difference in those subgroups, but they were largely underrepresented. And in terms of micrometastatic disease, we already really talked about that. These were all micrometastatic. A lot of the Z11 trial ended up being micrometastatic as well, and there was no difference in outcomes. Most patients, not defined in the B32 trial, but in these other two trials, the vast majority of the patients received systemic therapy of some type. Most of the patients were ER positive and got at least endocrine therapy. And then finally, with regard to type of surgery, when we're talking about does this apply to mastectomy versus lumpectomy, the Z11 trial had no mastectomy patients in it and smaller percentages of mastectomy patients in the other two trials. So in these trials, no difference in outcome for the mastectomy patients, but the numbers were fairly small. So let's look at the NCCN guidelines. The NCCN guidelines were updated with regard to evaluating axillary nodes in 2017. And so the NCCN guidelines now say that really for all patients T1 through T3 that are clinically node negative can all go to sentinel node biopsy. Regardless of histology, they can all go if they are clinically node negative. And then for patients that have micrometastatic disease only, no further axillary surgery is recommended. So they've come down on the side of supporting the data about micrometastasis. On the macrometastatic side, the NCCN guidelines reflect the Z11 criteria: small tumors, only 1 or 2 positive nodes, breast conserving surgery, and with plans for whole breast radiation therapy. So if you're not going to meet those criteria, our NCCN guidelines still recommend level 1 and 2 axillary dissection. Although I will say that we're not all doing that. Okay, John, why did all of a sudden this popped up to... Okay, there's speaker's notes in here too. I don't know why. It may just... It may be that it... I don't know. Just put it back up. It's okay. There it goes. Okay.
Try to click right here.
Yeah, I don't...
Nope.
No.
This one.
Just put it back.
That's it.
There. Okay, so we're back. Sorry. Okay. So there's still a huge number of questions with regard to all of these issues. And so there are a couple of trials that are going on now. The Cinemac trial, which is a Swedish trial based in Stockholm, is a non-inferiority trial that's going to enroll 3,500 patients. It's still enrolling patients. These are clinically node-negative cancers that end up having up to 2 nodes that are positive, and will randomize patients to no further axillary surgery versus node dissection. It's going to allow mastectomy patients. It'll allow neoadjuvant chemotherapy. It allows T3 patients. So it's got broader criteria than the Z11 trial did. The second is the CIRC trial. This is a French trial, also a large trial accruing 3,000 patients. These are clinically node-negative, small tumor T1 and T2, only breast-conserving surgery, and node-positive will randomize them to no axillary node dissection versus axillary node dissection. And the difference in this trial from Z11 is that this will allow any number of positive nodes. One of the criticisms of the Z11 trial was the lack of standardization of the radiation field in the lymph node, in the sentinel lymph node arm. And whole breast radiation using tangential fields does radiate the lower level axillary nodes. And so there have been questions all along about whether those patients that are node positive that don't have a dissection are actually just getting treated with radiation. So this has precipitated a big discussion about the extent of radiation therapy for node positive patients. So these are some of the trials that have been done that we base, especially the Amorose trial, we base a lot of our modern treatment on. The Canadian MA20 trial was a large trial with node positive and some what are called high-risk node negative patients that got whole breast radiation or whole breast irradiation with RNI, means regional nodal irradiation, which is supraclavicular, internal mammary, axillary nodes. All these women had breast-conserving surgery, and in this trial, with long-term follow-up, 10-year follow-up, there was no difference in overall survival, but there was a higher local regional recurrence rate in women that had whole breast irradiation only. So in other words, regional nodal irradiation decreased local regional recurrence. The next trial is the EORTC trial that had 4,000 patients in it with stage 1 to 3 disease. These were patients that were felt to be at risk for internal mammary node metastasis because they had medial tumors or they were axillary node positive. And so this was another trial where the patients got randomized to whole breast versus whole breast radiation with regional nodal irradiation. Well, in this trial, there was actually a better disease-free survival for patients that got regional nodal irradiation and a trend for overall survival, but not statistically significant. The next trial is the Amorose trial, and this is one that, that we quote and use every day. This is an interesting trial. It actually did not accrue its goal, and so it's somewhat underpowered. Despite that, this is the one everybody quotes every day. This was a trial that enrolled clinical node-negative patients with small tumors T1 and T2. And of the patients that were enrolled and were sentinel node positive, they got randomized to completion axillary dissection or radiation therapy to the axilla plus whatever other radiation therapy was indicated. So, so patients either, they had one of the two treatments which were pretty drastically different, either no further surgery and nodal radiation or axillary node dissection without radiation of the axilla. And on 6-year follow-up, regional nodal irradiation was non-inferior to axillary node dissection in all measures: local regional recurrence, overall survival, and disease-free survival. So this has really had a huge impact on how we practice, because this trial says that you don't have to do axillary node dissection and radiation. You may be able to do one or the other. One of the interesting things about these trials, and we'll talk about this a little bit later, is that the additional positive nodes in these trials for the patients that went on to have axillary dissection, in all these trials, the additional positive node rate is like 30%. It's a huge percentage of patients that were leaving positive nodes behind in these prospective trials. So, good grief. So that's been a really been an interesting finding. So what is happening in real life, out in practice, as a result of some of these recent publications, and how are people looking at this? This is a Dutch study from 2011-2015, a review of about 45,000 patients with breast cancer treated during that time period. And the use of completion axillary node dissection for sentinel node positive patients decreased from 75% to 17% in that 4-year interval. So that's pretty remarkable turnaround in how we practice. So the things that correlated with elimination of completion axillary dissection, let me put it this way, the things that correlated with continued use of completion axillary dissection were earlier year of diagnosis. In other words, patients in 2011 versus 2015. That was soon after some of these publications came out. Younger age was more likely to undergo completion axillary dissection, mastectomy, lobular histology, high-grade cancer, and the patient having surgery in a non-teaching hospital. So even though the use of node dissection dropped dramatically, the drop in node dissection in patients that underwent mastectomy happened at a much slower rate. So let's go back to the NCCN guidelines, because in the past, when we talked about radiation, of course, patients that have breast-conserving surgery are mostly going to have radiation. But what about post-mastectomy patients, and what do we do with mastectomy patients that turn out to be node positive? In the past, we only recommended post-mastectomy radiation for patients that had 4 or more positive nodes, and then on prior versions of the NCCN guidelines, there was a recommendation to at least discuss post-mastectomy radiation in patients that had 1 to 3 positive nodes. The latest version of the NCCN guidelines have changed this to strongly consider radiation therapy to the chest wall and nodal basins. So this represents a shift, and because there's now really sufficient data to warrant that. So let's look at some of that. This was really the big review that has influenced how we view this topic, because there were some trials out there showing a benefit to post-mastectomy radiation in 1 to 3 positive nodes, but they were either only European trials, they were small trials. We weren't really sure how to account for all that, but this is a big review looking at radiation therapy after mastectomy with 8,100 women in 22 different randomized clinical trials. So this is a big meta-analysis. And so this required inclusion of an axillary node dissection that include level 1 and level 2, had to have greater than or equal to 10 nodes removed, and then looked at the effect of radiation therapy versus not. And the thing that's interesting is that post-mastectomy radiation therapy, which we have always considered as a controller of local disease, does that well, because Local regional recurrence in this group of patients, N1, which is 1 to 3 positive nodes, was 3.8% versus 20.3%. The thing that's really amazing is that the 20-year follow-up of breast cancer mortality is also diminished, so relative risk of 0.8. So what's really changed about the conversation with regard to radiation therapy is that radiation therapy appears to have an effect on breast cancer mortality as well. And we're not going to really go into all that today because there's so many, that's a whole other talk about why that may be and what may be going on with radiation therapy. But these numbers are remarkable, and regardless of how you feel about radiation therapy, these numbers are there, and they're not going away. So these are just the slides that show local regional recurrence, any first recurrence of breast cancer mortality, no radiation therapy versus radiation therapy. The curves are statistically separated. So that recommendation, post-mastectomy radiation for 1 to 3 positive nodes, is something that is part of our practice at this point. There are a couple of other ongoing trials that are going to provide more data for mastectomy patients. The BOOG trial is a Dutch trial. Figures it has a lot of vowels in it. Dutch trial that compares completion axillary node dissection or regional nodal irradiation in mastectomy patients. Small tumors found to have N1 disease up to 3 nodes, and both micro and macro METs are included, and so they're going to look at outcomes in this group. In the second one, the POSNOC trial is a British trial, 1,900 patients, and so these are women with with T1 or T2 tumors, clinical N0 with 1 to 2 micromets in the sentinel node biopsy, and they will be randomized to observation versus axillary node dissection or nodal irradiation. So there's actually 3 arms here to look at recurrence. So those are ongoing trials that we'll have information about at some point in the future. Okay. So we'll get back to, these are back to some of our clinical questions that we run into every day at tumor boards. So this is a 60-year-old woman that had a mastectomy, small tumor, ER/PR positive, HER2 negative. She had 1 sentinel node with a 2.1 millimeter met, which is technically a macro met, just by a hair, no extracapsular extension. So what do we do with her? Node dissection, no further treatment, post-mastectomy radiation with regional nodal irradiation. So what do we do with her? I would say that based on our post-mastectomy radiation data, that a lot of us would recommend that no further axillary surgery, but post-mastectomy radiation treatment based on the Amoros trial that showed that that was equivalent axillary control. So this is another typical scenario that we run into. This is a larger tumor in a 52-year-old one, high-grade triple negative. She had clinical N0 disease to begin with, got neoadjuvant chemotherapy, then she had mastectomy in a sentinel node, which would be appropriate. And she had 1 node removed and it showed treatment effect. So what do you do with her? Node dissection, radiation. So she had a positive node at one time, now she doesn't. What do we do with this one? I don't think we know what to do with this one. A lot of people would recommend radiation anyway because she presumably had positive nodes to begin with. So kind of in summary of this segment of the clinically node negative patients that's found to be node positive. So there's good information for elimination of completion axillary dissection in micrometastatic disease, in patients having breast-conserving surgery with 1 to 2 macrometastatic deposits. And then there's mounting data for applying this to mastectomy, especially in the setting of post-mastectomy radiation, because it appears to control nodal disease as well as surgery does. And like I said before, the interesting thing about all of this is that in the various trials, the number of additional nodes that are found in the arms where completion axillary dissection is done is very high. It runs between 13 and 35%. But it doesn't appear to affect anything. Local regional recurrence, overall survival, it doesn't change anything. The areas where we're still not clear about what to do, infiltrating lobular cancer, which is about 10 to 15% of cancers, we don't know. We just don't have enough data on that group. Larger tumors, we don't have much data. Should there be an age cutoff, very young women? We don't know. We don't have enough data on that. And then what do you do about patients that show treatment effect with an obviously treated node? So I'm glad we got all that cleared up. Okay, so let's go on. We're going to go on to the second part, which is a clinically node-positive patients. And we need to talk about what clinically node-positive means. Is it palpable disease versus image findings versus biopsy proven? Palpable disease implies a larger nodal burden, whether it's the size of the met or the number of nodes or whether they're matted nodes. Some of the studies that we'll talk about exclude palpable disease from eligibility. A lot of them don't specify. It's kind of all over the map as to how people are classifying these patients. There's some data to suggest that PET scanning has a sensitivity of only about 50% for nodal disease, but the specificity is greater than 95%. So if you have hot nodes on a PET scan like on this one, you can count on those being positive nodes. For very small deposits, PET, less than 5 millimeters, PET is not going to be helpful because it's not going to pick those up. What about axillary ultrasound? Some places perform axillary ultrasound for all invasive cancers. We do that here. Others are selective. If the ultrasound is suspicious, should you do a biopsy? Should you do a core biopsy? Should you do an FNA? And if it's positive or negative, then how's that going to affect your surgery? So these are all questions that come up with regard to this topic. Okay, so these are a couple of patients that we'll talk about, then we'll come back to. This is a 42-year-old woman, clinical T2 tumor, larger tumor, N1, invasive ductal cancer grade 2, ER/PR positive, HER2 negative. So she has one axillary met biopsy proven by FNA. Staging scan is negative. You send her to the medical oncologist, and they've done all the staging workup, and they send her back and say she needs surgery first. So this is biopsy proven N1 disease, where you're doing surgery up front. So how will you manage the axilla? Node dissection, so-called selective or targeted axillary dissection, or sentinel node biopsy. And what about this patient? 43-year-old woman with a relatively small tumor in the upper outer quadrant and at least 5 to 6 positive nodes of the right axilla, all of them much larger than the primary tumor. She has a grade 3 triple negative cancer and an FNA of one of the nodes that's positive. No other distant disease by staging, genetic testing negative. She had neoadjuvant chemotherapy with a complete clinical response. All her nodes look normal and her tumor appears to be gone. What do we do with her? So let's jump into this confusing topic of clinically node positive. We're going to look at some of the definitions. We'll discuss what happens with surgeries done as first treatment, or if it's done after neoadjuvant chemotherapy, then what do we do? Clinical stage N1 disease is determined by our AJCC 8th edition staging manual. Clinical stage 1 is palpable mobile axillary nodes. That's one criteria. N2, palpable fixed or matted axillary nodes. So pretty advanced axillary disease, and we don't see this present that often. Sometimes we do. But clinical stage does not account for the number of nodes involved, as does the pathologic stage. So this is the only criteria. It does not speak to numbers. There is an implication that palpable nodes imply a greater tumor burden than nodes only seen on imaging because they're simply larger and contain more disease. Within AJCC staging, though, imaging with ultrasound, MRI, CT, PET-CT can identify non-palpable abnormal nodes, and you can classify these nodes as clinically N positive without histologic confirmation. The AJCC allows you to do that. You can also classify node positive by FNA, by core needle biopsy, or by sentinel node done prior to treatment. So that's not done very much anymore, but it has been in the past. So the staging rules allow you to do all of those things. And so there are potential problems with this because biopsy is usually performed of only one node, so the total number of nodes is uncertain. And so common sense would tell us that there's a difference between a patient with one positive node and 8 positive nodes, but they both can be clinically staged as N1. This generates difficulties in discussing management and applying clinical trial results because it's just a heterogeneous, can be potentially a heterogeneous group of patients. And this is where the surgeon's participation in tumor board is really important because this is where you do the clinical staging is in your tumor board. Pathologic staging is often done by the pathologist and signed off on sometimes by the surgeon, but the clinical end stage is done during tumor board. And so what do you do with these nodes that are borderline abnormal? The cortex looks a little thickened on ultrasound, but it doesn't look grossly abnormal. There's no definite answer for this, but you as a surgeon need to be able to participate in the discussion because it affects the direction of patient management as far as whether you as far as how you determine the clinical end stage. There's quite a bit of variability among different centers in evaluating the axilla, and just talking to people around the country, it's all over the map. Some people want to know everything. Other people don't want to know anything much. Some centers evaluate the axilla only with exam, and if there are no palpable nodes, they get staged as N0. Some centers do some degree of imaging. We're kind of in this boat. We generally do axillary ultrasound. Some centers do extensive imaging with PET-CT, MRI on every patient, trying to gain maximal information. So as we talked about earlier, if the patient's classified as clinically node negative, then you can have sentinel node pursued upfront with surgery or after neoadjuvant chemotherapy. But if the patient classifies as clinically node positive at the beginning, her situation becomes a little more complicated. Most of the time, this implies more advanced disease, and so there's going to be at least a consideration of neoadjuvant therapy to downstage the axilla, hopefully avoid axillary dissection. The problem is, in patients that have surgery first, the recommendation is still to proceed with axillary dissection in a known positive axilla. And this is reflected again in the NCCN guidelines. Clinically node positive, biopsy positive goes to level 1 and to axillary dissection. Although I will say not everybody's doing that. but that's what our guidelines say. So let's look at patients who get neoadjuvant chemotherapy in the setting of clinically node positive. Patients that get neoadjuvant chemotherapy and have persistence of axillary adenopathy after therapy, that is an indication for axillary node dissection. So they don't really need any other evaluation. They don't need a sentinel node biopsy. They just need a node dissection. But what about patients who resolve their adenopathy? Can they have a sentinel node biopsy, or do they all need to have axillary node dissection? And what information do we have about performing sentinel node biopsy after neoadjuvant chemotherapy in patients that were node positive? This gets into questions about accuracy of that kind of evaluation, and is it adequate? So this question has actually been addressed in several clinical trials. The NSABP B27 trial was not established to study this question. This was a trial that randomized patients to 3 neoadjuvant chemotherapy regimens. But as part of this, during the surgery phase of treatment for these patients, about 18% of them underwent sentinel node biopsy followed by axillary dissection just to see what kind of outcomes could be obtained from looking at this group. So these were node positive patients at the beginning, sentinel node biopsy, axillary dissection. And so the identification rate for sentinel nodes was 84.8%. The modern day identification rate for sentinel nodes, that means does the procedure work to label the node, is near 100%. It's about 95% in patients that are clinically node negative who haven't had any other treatment. So it's quite high. So this ID rate was fairly high, but not terrific. And the false negative rate was 10.7%. In other words, you had negative sentinel nodes, but you really had positive nodes left behind that weren't identified. The standard false negative rate for sentinel nodes, based on all our past trials, is about 10%. And that is actually the false negative rate for axillary node dissection when we used to do that as primary treatment. So that number is out there as a comparison. Get to the next. The Centina trial, which was published in 2013, had 4 arms, 2 for clinically node negative, 2 for clinically node positive. And the criteria for positive was palpable nodes or abnormal ultrasound. All the patients got neoadjuvant chemotherapy, and then their node status got reassessed. So in the group that had persistent abnormal nodes, they went to axillary node dissection. The patients that got converted to node negative had sentinel node biopsy followed by axillary dissection, so they did both procedures. And their sentinel node identification rate was pretty good at 80%. The false negative rate was high at 14%, but if more than 2 nodes were removed, the false negative rate fell quite low to less than 10%. Another really important trial for us was an ACOSOG trial, 1071, published in 2013. So this was a U.S. trial. Clinically node positive patients who got neoadjuvant chemotherapy all had sentinel node followed by axillary node dissection. Identification rate was high. False negative rate was 12.6, considered too high, but it dropped to 9% when at least 3 nodes were removed. The other thing that was noted is that when dual tracer was used for labeling, which means using the radioactive tracer plus blue dye, the false negative rate was also much lower. The identification rate was also elevated by using dual tracer. The SN-FNAC trial was clinically node positive patients, neoadjuvant chemotherapy, then same thing, sentinel node biopsy followed by axillary node dissection. Their ID rate was high at 87.6% with low false negative rate. Again, with at least 2 nodes removed, and a lower false negative rate with use of dual tracer. So we have 4 clinical trials showing that sentinel node biopsy can be accurate if you meet certain criteria. So the recommendation now is for use of dual tracer, identification of at least 3 sentinel nodes. So you have to work hard to find those sometimes. And there is also the issue of locating the previously biopsied node with some type of marking or clipping and then operative retrieval. A recent study from MD Anderson found that the clipped node, the previously biopsied node, was not retrieved as a sentinel node in about 23% of the cases. So there are various means to localize this node and try to retrieve it. All of these trials that we mentioned didn't require retrieval of that node and didn't really comment on whether the sentinel node had been removed. So, but that this is an area that people are talking about and concerned about. So, in terms of how you label the node, you can put some type of ultrasound visible marker at the time you do a node biopsy. This is a abnormal axillary node. That little squiggly metallic marker on there is a fairly large metallic marker that is put in at the time of surgery. You can either try to find the node with ultrasound, which can be difficult. You can try to wire lock the node, which can also be difficult because just visualizing the axilla with either standard mammography or stereotactic can be difficult. Another route to pursue is use of a reflector. This is a little device called Savvy Scout. It's a tiny little metallic marker that's injected through an 18-gauge needle, so it can be put in any time. It's not radioactive. It's just has a reflector surface, and you actually use a radar-type device to locate it in the operating room. You can use this to localize tumors, but it's also very helpful for nodes. And then you can image the specimen to see if you got out the appropriate node. So there are other complexities related to sentinel node biopsy after neoadjuvant chemotherapy. If your center uses PET-CT and the PET positive nodes become PET negative, then you can probably do a sentinel node. If the PET scan remains positive, then you probably just need to go to axillary dissection. So one of the things that's emphasized in all of these settings is that if you're going to do sentinel node and then make a determination about axillary node dissection, you need to do frozen section or touch prep. You need to have an intraoperative assessment of the nodes. So should we do sentinel node biopsy after neoadjuvant chemotherapy? So if it's an accurate procedure and the patient is converted to node negative, then you can avoid an axillary dissection. In the ACOSOG study, the Z1071 trial, that was about 40% of patients. So that's a huge number of patients that can now avoid axillary dissection if you follow all these rules. They become node negative, you take out 3 nodes, you use dual tracer, et cetera, et cetera. The St. Gallen group has met with a consensus about sentinel node biopsy after patient presenting node positive who becomes clinically node negative. St. Gallen recommends removal of at least 3 nodes, and they were undecided about whether completion axillary dissection is needed in micrometastatic disease. NCCN guidelines have also altered the approach to node positive patients. The NCCN does allow restaging of the axilla for persistently positive nodes. Then the patient needs axillary node dissection. If the patient has become clinically node negative, then sentinel node biopsy can be performed with all of the caveats we talked about before, use of dual tracer. NCCN recommends removal of the marked node that was previously biopsied and was positive, and removal of 3 or more nodes, and then examination of the axilla to remove any obvious abnormal nodes. This guideline does not make any comment about micro Mets versus macro Mets. So, are there any situations where we should forget about doing sentinel node biopsy after neoadjuvant chemotherapy? Are there any patient subsets that have such a low likelihood of conversion to pathologically negative that we should just go straight to axillary dissection? Response of different tumor types to chemotherapy has been pretty well documented in the literature. So at a recent review by Memorial Sloan Kettering, looking at node-positive patients who received neoadjuvant chemotherapy, the rate of nodal complete pathologic response was 97% in ER-negative HER2-positive cancer at the high end, and lowest at 21% in ER-positive HER2-negative disease. And this goes along with what we observe every day. It's very difficult to render an ER-positive with a complete pathologic response. This is specifically talking about the nodes. So the problem here is that if you have a complete pathologic response in 21% of ER-positive patients who get neoadjuvant chemotherapy, that ends up being, numbers-wise, a lot of patients because most patients are ER-positive. So there's really not a subset of patients that you would say that you wouldn't do a sentinel node biopsy on. What about micrometastatic disease? What do we do about those patients? Memorial Sloan Kettering recently reviewed 700 patients, sentinel node biopsy after neoadjuvant chemotherapy, who were rendered clinically node negative. And so they looked at sentinel node biopsy followed by completion axillary dissection. 64% of the patients with micrometastatic disease had one or more additional positive nodes at the time of axillary dissection. So their conclusion from looking at this was that even with micrometastatic disease, the patients should undergo completion axillary dissection. The problem here, the difference between this situation and finding micrometastatic disease in the upfront sentinel node biopsy setting before any treatment is that, by definition, anything that's left in the axilla now is drug-resistant disease, and so that's a different situation from leaving disease behind in a patient that hasn't been treated yet. So that was their recommendation. Okay, so what about this whole issue of adjuvant nodal irradiation for positive sentinel nodes after neoadjuvant chemotherapy? There are a couple of trials that are accruing. We don't have either of those open here, but what about this whole issue of radiation? If patients are going to get radiated anyway, do you need to do an axillary dissection? So the NSABP B51 is a trial which is randomizing patients who start out as clinical N1 and have a complete pathologic response based on node dissection. So there's no sentinel node in this one. These are patients that have an axillary node dissection. All their nodes are negative. In this trial, the patients are then randomized to axillary radiation versus no axillary radiation. Traditionally, recommendations for radiation therapy have been based on the node status pre-treatment. So for a patient that has obvious positive nodes pre-treatment, no matter what their pathologic status is at the time of surgery after neoadjuvant chemotherapy, they still get radiation most of the time. So this is a trial to look at, if you get a pathologic complete response, is there any additional benefit to receiving axillary radiation? The Alliance trial, which is actually kind of more interesting, are T1 through 3 patients who have a positive sentinel node biopsy after neoadjuvant chemotherapy. And so these patients are being randomized to the question we really want to know, axillary node dissection or axillary radiation. So these are persistently positive patients. In this trial, the patients receive radiation to the remainder of the intact breast or the chest wall and internal mammary supraclavicular nodes. The randomization is to axillary radiation or no. And so this trial is currently accruing and enrolling patients to try to answer that question. So let's look back in summary, because one of the questions about axillary dissection that's being asked, and this gets debated every year at the breast surgeons meeting, is axillary node dissection going away? Or are we not going to need to do this anymore? Are breast surgeons going away, breast surgery going away? Are we still going to need to do this? So is it still relevant, or is it going to be a relic of history? So in a lot of situations now, small tumors, clinically N0 sentinel node positive, if a patient just has micrometastatic disease, there's no axillary dissection. Patients who have breast-conserving surgery and macromets in 1 to 2 nodes, it's considered a relic. Those patients can be treated with radiation therapy and systemic therapy. Mastectomy patients, if they're going to have post-mastectomy radiation anyway, then we go back to quote the Amorous trial that shows that radiation is equivalent in terms of axillary control to surgery, then we probably would not pursue axillary dissection. In situations where we don't have a lot of data, invasive lobular, young age, no planned radiation therapy, that is still considered appropriate and probably falls into the realm of discussion at your tumor board as to what you would recommend for the patient. And patients and lymph nodes that are persistently positive in the post-neoadjuvant setting are relevant. In patients who start out node positive, surgery first, biopsy proven N1 disease. We just don't have any data to say that you can do anything different than an axillary dissection. When you think about it, I mean, we're patients that are found to have positive nodes, we don't do an axillary dissection. Why will we do it up front? The problem is we just don't have any information. People have talked about all kinds of variations on axillary dissection, directed, therapeutic, targeted, all kinds of terminology that are sort of partial axillary dissections. There's just not a lot of data out there about what exactly they're talking about. So for surgery first, most of the time it's going to be an axillary dissection. In the setting of neoadjuvant chemotherapy, patients that don't get a clinical response, they still need axillary dissection. They have drug-resistant disease that may need surgery and radiation as part of their treatment. If you can, you know, it's best if we can enroll patients in clinical trials at this point to try to answer the questions. You can, you can accomplish sentinel node biopsy in the post-neoadjuvant chemotherapy setting if you can establish all the appropriate criteria, dual tracer use greater than 2, probably 3 nodes, and removal of the labeled node. Okay. So hopefully that's sufficiently confusing to everybody. This is really, I mean, the whole topic is such a tangle of different studies and what to do. The thing that has dramatically, probably most dramatically changed outcomes for the patients has to do with systemic therapy and with tailoring systemic therapy to the individual and to their particular tumor. And so, some of these things that we're agonizing over with regard to the axillary nodes, I think in the next few years they're going to get answered. I really, I have a lot of respect for Monica Morrow, who is the chief of breast surgery at Memorial Sloan Kettering, because Monica always just kind of cuts to the chase, and rather than getting lost in endless studies. And her view of all of this is that everything that's happening with the patients is the tumor biology. And so you've got to address the tumor biology. The other things that we're doing are sort of cleanup, or they're sort of, they may be helpful, but we're kidding ourselves because, when we're leaving possibly a third of the patients with positive nodes when we don't do an axillary dissection, and they do the same as when we do an axillary dissection. That's all about tumor biology and systemic treatment. That doesn't have anything to do with surgery. So anyway, lot of confusion right now, and a lot of difficulty in trying to sort through what to do. So John, you want to bring the lights up, and we'll...
Yeah, we're past time, so we need
Yeah.
to, if there's anybody got a brief question or comment. I think to reiterate, for residents, trying to think about the residents out here, Laura, and
Yeah.
how if they're going to be taking oral boards, this November or December. The main thing I would tell you, because you got so much to cover to study, to cover all of general surgery, then be sure you understand the biology, which you made the point at the end, because that's the thing that is probably dictating outcomes much more than a lot of these other things that we do surgically. So it's really important for you to know that when somebody asks you a question, gives you a scenario of a patient with a problem in terms of HER2 status and all that. So she's referred to that several times, so just know that. And that with axillary nodes, as long as you understand the biology, the anatomy, and what happens physiologically, then there are very few wrong answers to it. Generally, for a surgeon, you're better off to be more aggressive than not, but only up to a certain point. And what I would tell you too is you can always rely on that in axillary, in a question about the axilla, is that there are lots of studies that have been done, a lot of studies are ongoing, and so I would collaborate with my radiation oncologist about what to do, and that's the best reasonable answer, I think.
Yep.
One brief question now, because I know in the past you and I have talked about this. The patient that you're doing a mastectomy on, clinically node negative, but you're doing a mastectomy, do you do a frozen or touch prep on the sentinel node?
I don't anymore.
Yeah, I know, because we used to talk about that, but don't anymore. And so that's just another point, because it's not going to change anything if they're clinically node negative, most likely. If you had 3 of them and they're all positive, then you'd have to talk to your radiation oncologist about what we need to do, probably.
Right. That's where, the multidisciplinary conference is important, but the surgeons have a very important role in their conferences.
Right,
sometimes.
Right. And the other thing that you alluded to, just want to reemphasize, is the clinical evaluation of the axilla is really important. And so again, if somebody's asking you a question and giving you a scenario, then be sure you include that after I make my incision, even using dual tracers or whatever you do, you palpate the axilla. Because a node that is packed full of tumor will not pick up either an isotope or dye. And so that becomes an important thing for you to know, because that's how a lot of these are missed. I wish we had time for more questions, but we're past time.
Okay.
We'll have to stop. Yeah, okay, yeah.
I never saw any mention of lymphedema
Oh,
in
yeah.
these patients. The incidence versus node dissection versus radiation.
This is,
And that's what you're trying to avoid, but I saw
That's what we're
nothing on
trying to
lymphedema.
avoid. Yeah. The problem is the estimated incidence of lymphedema is a pretty broad range. For axillary node dissection only, it's somewhere between 15 and 35%. I mean, estimate, and with risk factors, obesity being the biggest risk factor. The incidence of lymphedema in the Amorous trial, or complications of all type, was lower for radiation therapy than it was for axillary dissection. The real killer is axillary dissection followed by radiation therapy, because then the incidence is 50%. So now, and let me tell you, the patients are aware of this, you really have to talk to the patients. And so sometimes you need to do both things, but I tell them that the incidence of lymphedema is 50%. And there's nothing that we can do about that because of their particular situation. I had a lady this week who had probably 5 positive nodes. They all got smaller. She still had tumor in her breast. We did dual tracer. The tracer didn't migrate at all. It didn't migrate at all. And so either she still got disease in her axilla, she probably does. So I did an axillary dissection on her, and I talked to her. I said, I can't do anything about your cancer. I can't help that you came in with a 5-centimeter cancer and 5 positive nodes. We're just dealing with what we've got left. So, so she's going to end up getting both. But I think it's just, you just can't have the patient surprised. They can be unhappy about their news, but no surprises. So you really do have to talk to them up front about that. Yeah.
Okay, thank you very much.
Thanks.